Hello, and welcome back to SYNLAB podcast series on effective malaria diagnosis. This is the episode 3. My name is Uchenna Amadi, and I'm your host. In this episode, we're talking about getting the diagnosis right. And I'm still with the incredible Dr. Owoeye and Dr. Ajibawo. Please do not forget to like, subscribe, share, and follow SYNLAB Nigeria on YouTube and Spotify. So far, we have established that not everybody has malaria. Also, not every fever is malaria, and that children are especially vulnerable. So parents and caretakers should also be aware. Now, moving into getting the diagnosis right, I will be starting with Dr. Owoeye. Could you tell us the reliable methods that are available for malaria diagnosis today?
Okay. I think I'm going to be talking about all the methods, and I'm going to be talking about the merits and the demerits of each one. If that's
I should carry my jotter.
Well, first is the rapid diagnostic testing, which is readily available. You can even get it in pharmacies, even in the village, health center. You could actually get it there because WHO has actually recognized it as also important and key in screening for malaria infection. So I'll start with that. Now, the rapid diagnostic testing, basically, it's readily available, it's affordable, and then you can actually get the results on time. Within 15 to 30 minutes, the result is out. That's one of the... So it allows for immediate, decisions to be made. So, and it's basically something that you can have hands-on. You understand, and then run the test. And the basis basically is it uses some of the characteristics of the malaria parasite. You detect that. The kit is actually embedded with some certain characteristics that allows you to be able to detect malaria proteins in the blood.
Okay.
And of course, it's very easy to read. I mean, you can even have the RDT, even you yourself. You can do it.
It's like a self-testing kit.
Not really. It's a self-testing kit. It's not. It's a self-testing. What I'm saying is, for anyone using the RDT, any healthcare provider, you don't really need to be a specialist in malaria diagnosis for you to be able to know that.
It doesn't require like a high level of professionalism.
Exactly, to be able to see. So you can easily identify this is what it is. And then, but one of the drawbacks, is that when you have a low parasite load, you usually cannot detect it. You would have false negative.
So that's the limitation.
That's one of the limitations. Then again, it does not allow you to be able to identify the species of the malaria. So you cannot say that, this is P. falciparum, or this is ovale, malaria, nonlesi, or whatever, that it is. But then it helps you to be able to identify malaria infection. Another thing about the limitation is in some of those kits can even still be positive for malaria infection weeks after the malaria has been cleared.
So past infections.
Yes, have been cleared. Some of them for weeks after it can still, become positive. So that means you can have false positive. You can also have false negative. And also 48 hours after, a treatment of malaria, usually it's not advisable for you to actually do testing because usually you're not going to get a reliable result, within that period. And so these are some of the things,
because people do.
Yeah. So
somebody will just take anti-malaria today and now go to the lab.
Yeah.
What are you expecting?
And then, do that. So, these are some of the limitations of the rapid diagnostic testing. However, it's still very, very much reliable in the diagnosis of malaria. And of course, it has allowed healthcare providers be able to reach, a wide number of people. Because how many health centers will you actually see microscope? And even if you see, especially in sub-Saharan Africa, how many trained microscopists will you actually get? Because, to diagnose malaria needs serious training. It needs specialized training.
Yes.
You understand? So it's not just that, I've been looking at the microscope for 5 years. If you're not trained...
What are you seeing in that microscope for 5 years?
So, like one of my lecturers will say that the microscope is as good as the brain behind it.
You
understand? So
please say it again for the people in the back.
so and that will now bring me to the gold standard microscopy.
Yeah.
And it's the gold standard because you can actually through preparation of the thick and the thin film, you can actually detect the density of the parasite, and you can actually look at the particular species of the parasite that you are dealing with.
Okay.
So with your thick film, you'll be able to identify the density of the parasite.
Yeah.
With your thin film, you'll be able to identify the particular species and look at the stage of, infection. So it's the gold standard because you actually seeing it. Just as I always tell people all the time, I used to say that even let's shift a little bit away from malaria. I would always say that the peripheral blood film review is always the quality control check for, whatever the machine is, because they're actually seeing, but then, as I said earlier on, the what you get from the microscope is as good as the brain behind it. So the major drawback is, the experience of the person, the competence rather of the person behind the microscope, which again is a major problem. You understand? Because in most settings out there, thank God she's a primary care physician, most of those settings in the country, you're not actually going to get any trained microscopists there. Wow. Even if you have a microscope in a primary health center, it's just there gathering dust. Nobody's checking anything.
Wow.
So that is why and that is why over the years, there's a lot of improvements that have come onto the RDT screening kits to be able to help us to be able to, at least to a very large extent, be very specific in the diagnosis. RDT kits are actually very specific, for, malaria and stuff. So that is a major drawback for microscopy. You actually need highly trained, specialized persons to be able to check and look at it. And then there's as a rule of my practice, most of the times when I see people reporting 1+ of malaria.
Doctor, wait, let me sit well.
90% of the time,
a lot of people are guilty of this. Yes. There are places you would go to, and as the patient, you will always come out with 1+ of malaria. So that I don't know how to say this, but it now gets into the patient's subconsciousness. When you now tell them they don't actually have malaria, they want that 1+ there because they believe that everybody must have malaria. So I think this goes to the competency parts that you're talking about. Please say it again for the people at the back. How can we address this issue? Because it's recurring.
Yes.
A lot of people have fallen. This is when we're asking about the risk of always treating malaria over and over again. This is actually one of the root causes why people go back and treat again, because they always get that 1+ result. Yeah. So please, how can we address this issue?
Okay. And I'm actually going to say something about this, because even if you do RDT and your RDT says you're positive, it does not actually mean you have malaria. Because if you have had the malaria, if you have had a malaria infection recently and you've had a treatment, you can still have it being positive for the malaria antigen, especially if it is an antigen-dependent kit. Because the malaria infection could have been cleared, and then you still have a positivity to antigen for weeks, even after your treatment. So a 1+ of malaria, more often than not, is not malaria. And I will back this up by what we've been able to do at SYNLAB. And that will take me to the next, method of testing, which is the automated machine, that we have. There's a machine, that we have that it can detect, P. falciparum, and then others. Now, the drawback there is for that particular machine is it cannot differentiate the other species. It can only differentiate P. falciparum. Okay. And for me, I think it's very relevant to us in this part, because most of the malaria infection we have is actually from P. falciparum. So it will show P. falciparum and then the others. Now, beyond that level, it actually also quantifies the level of the parasitemia, the level of parasitized red blood cell, because it measures the total red blood cell. It measures the percentage of parasitized red blood cells, and then so you can actually see. And oftentimes when we have results from clients, and then they come in with 1+ of malaria, and then I do microscopy and they say, and I don't see any malaria parasite, and then they are querying the results, and then we now say, okay, let's do the automated machine. You find out that a whole lot of times the result comes back, and then you are seeing 0% of RBC parasitized. The most I've ever seen is 0.1.
Wow.
Which is actually not even clinically significant. So that is actually underlining the fact that, we over-diagnose. And it's because some of these technicalities, the people that are, there do not really understand it. And I also think, again, the pressure. I mean, we were having this discussion not too long ago that sometimes a patient comes to you, you have to treat as a doctor. And then, because malaria symptoms are not specific, and you tell the person, you don't think the person has malaria, the person brandishes you a bad doctor. You don't know what you are doing. So I see a lot of healthcare providers just kind of doing it to just to dismiss the patient because, of the pressure. And because of certain things that a whole lot of our allied, people in the allied fields also do. Someone walks into a pharmacy, and the pharmacist, by default, thinks this person has malaria, and you go to a primary health center, you're actually seeing a nurse on duty, and the person thinks, by default, you have malaria. So these things over time has actually contributed to the overdiagnosis of malaria that we have, within our space.
Yeah.
And the danger in that is that because there's overdiagnosis, when someone has a serious malaria infection, that is potentially life-threatening, we may even delay, or we may even have issues with actually handling it, because, again, the fact that we overdiagnose malaria has made a lot of people to think that malaria is just something you treat with kids' glove. Shebi is just malaria.
It's not
you
just
understand?
malaria.
So these are some of the things that, I have seen with, the diagnosis of malaria, where a whole lot of people are not really doing so much, in that regard. They don't really understand the little intricacies, about the diagnosis and treatment of malaria. And I see this at play a whole lot, because I see malaria almost every day on my table coming, and then people are bringing 1+1+, and most of the times you check the 1+ it's really not malaria. And malaria is also endemic in this part of the world. If you're actually using a kit that is dependent on the antibodies, you're actually going to actually see if you have had a malaria infection. It takes a while for the antibodies to, so these are things that people really need to understand, about malaria. And that's where the clinical angle comes into it. Diagnosis of a disease, it's not based on a laboratory report or a laboratory test only. I need to state this. A lot of times in Nigeria, some people, I've had to counsel a whole lot of patients. They reach out to me in my DM or WhatsApp, and then, I've gone to do this test. Doctor, what do you think I have? And I would tell you, have you seen a doctor?
What do you think I have?
Have you gone to the hospital? So, and I think I want to actually stress on this point here. Malaria diagnosis is not just about laboratory, whatever the laboratory says. You need to speak with your doctor. It's your doctor that would decide whether you need to be treated for malaria or not, because your doctors have been properly trained to know about all these things I said. So you understand? So it is your doctor that would decide whether you have malaria or not. So you can't just walk into any lab and then you do tests, you have 1+ of malaria, and then you assume that you have malaria. Speak with a doctor first. Let your doctor see you, examine, review your results, and review you. Yes. Not even your results.
Exactly.
We don't treat results, we treat patients.
Yeah.
So that's what I have to say.
Wow. Passionately spoken.
Yes.
True ambassador of malaria testing. Dr. Ajibawo, anything you want to add, please?
Yes.
Are there things you have seen that...
In fact, before you even ask, I would like to just cap what he has said by narrating some of my own experience with patients. With patients and what I've been telling them in my consulting room. And the question was, so that we don't lose track.
Okay, so I was asking, why is the reliable methods?
The reliable methods.
Okay, he has talked about the reliable methods. Yeah. But I would like to emphasize, like he said, that when you have a fever, you have to see your doctor. The doctor has to take a history. The doctor has to examine you, or at least test you, see some things about you, and then, if necessary, test you. If you have a fever, he probably will test you. But malaria testing is not the only test we'll do for a fever, because then you'll be able to identify other common causes of fever. Remember that malaria is not the only cause of the fever.
Sure.
So it's when we check you, listen to you. In fact, most of the times at my table, when I take your history, I'm sure for those that have malaria, I know they have malaria before they come back from the lab. Yeah, I know they have, because most of the times these days, when they go to a good lab, they probably won't come back with a positive malaria result, like Dr. Owoeye clearly pointed out, because those good labs, we do the right things and they won't have malaria. I've seen patients that come to me with malaria results from labs. And I said, why did you do this test? Positive results, by the way. And they said, I was feeling a kind of way. No fever? No, not really. Sometimes they had the fever, no chills. And they come with a positive malaria result and say, doctor, I just said I will come to the hospital. I don't want to be treating myself. I mean, you've already gone half of the way, And I'm like, okay, I need to test you here. And then we'll see. When they come back from the return from the lab, because I've seen that the things they are talking about, they probably have a common cold or something like that. And they come back with negative results from our own lab. And they are not happy. And they want to still be treated for malaria now that they've come to the hospital. I'm not going to treat you for malaria if your results... But they say they are holding a result from somewhere else. I don't know what goes on in that place you're coming from. You understand? So, but even the symptoms, I'm agreeing more with what another test, maybe a full blood count has shown. And you probably just have a cold. So they are unhappy. So sometimes I wonder, these labs that manufacture positive malaria results, are they doing it because they know that the people that they are serving, these their clients, are not going to go away happy if they don't have a malaria positive or a typhoid positive result? Or I think Dr. Owoeye has explained to us brilliantly that it's because of the skill, the level of, skill or competence of the person handling the microscope. So people should understand that malaria testing is when it is well done and it is negative, they don't have malaria. They should take what the doctor says they should do at that point in time. But the other thing I would like to say is that why patients are not happy, that to address the unhappiness of patients that they are not getting a positive malaria result when they feel that they should have malaria, is because of the medicine we have now been using in the last 20 plus years to treat malaria. If you know, we used to use chloroquine. We stopped using chloroquine. I know we still get to the medications area.
Almost everyone does.
But mostly now we use artemisinin combined therapy. In that combination, there's a part of it that doesn't just treat the person that has malaria, but treats the mosquito that comes to bite you.
Oh, wow.
That way, sterilizing the mosquito. And so in areas where they can afford to buy that ACT, they are treating their mosquitoes as well. So the only good thing that has come out of this overdiagnosis of malaria is that a lot of mosquitoes have been rendered sterile.
And that even
reduces the level of malaria.
So you can actually test negative.
Yes.
Wow.
So it's only in environments where the environment is, is such that it encourages the growth of mosquitoes that carry the malaria parasite, and they cannot afford to buy ACTs. So now they are really expensive. They used to be less than 500. Now I'm hearing all sorts of prices. Maybe they don't have they cannot afford to buy. That's why they use Agbo, right? They cannot afford to buy. Then in those places, we don't have their mosquitoes being malaria free. So please, if your doctor says you don't have malaria, you probably don't, and you don't need to treat malaria. You probably should ask the doctor, what should I then do? And then he will guide you.
Thank you very much for adding that to all that he has said. We've talked about why testing is critical before treating. I think we've addressed that. And then we've talked about, you've graciously compared the RDTs and the microscopy. And there is something I know that stands out when it comes to SYNLAB Nigeria. They like to do their validations.
Yes.
So they would compare the RDT and the gold standard. They will compare that automation and the gold standard. So there are approved validation reports to even show that there are standards in place. And even quality controls run. I also like when you mentioned about the automation. And I think that can actually help the children. Because I know it runs the full blood count and then the malaria.
Does the
and in 1 minute. So you can imagine, when she said that the child has to wait for that, not like the child has to wait, but that fever that is exceeding 24 hours should not be left unattended to. It means that if I can get a sample to run on that automated system, I can get that result that day.
And
that will
within 4
fast track.
hours.
Yes, that will fast track actually the treatments for the children.
And again, let me just add to that. It also helps you to be able to look out for the danger sign, which is severe hyperparasitemia. So it helps you to be able to determine that. And of course, I must add here that microscopy is actually comparable to the automated machine. The only drawback is the fact that, of course, it only identifies P. falciparum and others. I mean, it doesn't differentiate overly from, that's the only drawback.
But at this point, what do we want to use this?
All those other ones. No.
I just want to know if I have it or I don't have it, so I can take my drug and be going. Why? Well,
no, it's important.
It's important.
Okay.
But the benefit of not having to look out for the species is that we know that in Nigeria, it's mostly falciparum, and it's actually the worst.
Yes.
The most severe of the malarias.
Yes.
So even the RDT kits, the specific ones we use are actually testing. Most of them are testing for P. falciparum.
Okay.
So, yeah.
So let me stay on you, Dr. Ajibawo. What common mistakes do families and healthcare providers make when diagnosing malaria? I know you touched on it a bit.
Yeah.
We were talking about the microscope.
Yeah, so the mistake they make, like Dr. Owoeye said, is thinking they should just walk into a lab first. Yes.
A doctor.
It's not just about the lab test. You need to see a doctor. Because
So
the doctor
should come first.
Yeah, the doctor,
Then the doctor should send you to the lab.
Yeah.
Definitely.
And then you go back to the
the
doctor with the
doctor.
results.
Yes.
Thank you. So the doctor should come first because the doctor will look at not just fever. The doctor will be asking you for other symptoms which he may need to address. Those symptoms may tell if you have a complication, if you have you likely have a different condition. For instance, a meningitis or a cerebral malaria, or it's just a tonsillitis or it's a chest infection. And some of those things will require that you be admitted. Some of those things will require that you get not a tablet, probably an injection or an intravenous treatment. Some of those things that the doctor observed, such as dehydration, may require that you have IV fluids. So by not going to the doctor,
You're
not
doing
doing yourself justice because you can just go to a lab, they find something, and then they tell you to go to the next pharmacy and get some medicine, which you will not be able to hold down or which wouldn't work in your situation. Doctor even asks around your context to know which of the medicines will work for you, which ones you have had problems with in the past.
Okay.
If you are someone that likes to take medicine, then you'll be able to take twice a day. If you're not someone that takes medicine regularly, we will know that, the once a day medicines will probably the one that best suits you. Or maybe pregnant.
Yes.
The doctor is going to consider that before giving you a medicine. So while he's testing for malaria, testing your blood count, he's also testing whether you are pregnant, especially for those that have missed their period or don't even remember, So the doctor is looking out for a whole lot of other things than malaria plus.
Wow.
You understand? So you need to go to the hospital first.
Wow. Thank you very much for this insightful conversation. This is truly where science meets responsibility. Testing removes guesswork and unnecessary treatment. Please do not forget to like, subscribe, share, and follow SYNLAB Nigeria on YouTube and Spotify. Someone out there needs this clarity. Stay with us and we'll be right back.